Hello, and welcome back to the Glowing Mama Method podcast, where we discuss healthy and sustainable weight loss for women over 40. And today we have Dr. Sinéad Dufour here with us. Thank you so much for joining me today.
Thank you, Steph, so much for having me. I'm really looking forward to chatting with you today.
Yeah, so for anyone who doesn't know, Dr. Sinéad is the top dog of pelvic health as far as I'm concerned, and I think as far as a lot of the world is concerned. You have been at this for a very long time. Can you tell us a little bit about your background and what brought you to where you are today?
Yeah, of course. So I'm Sinéad Dufour. I'm an academic clinician. So yes, on the clinical side, I'm a pelvic health PT, and I'll kind of let you know how I got into that. But also I've kind of had like the research and academic side through my whole career. And so I think that's given me kind of some unique input sort of on both sides. I've been able to have like the clinical work I do inform what I would say is probably better, more important, meaningful research. And then I can always really make sure like the care I'm providing is substantiated by our emerging knowledge on the science side. How I got into pelvic health, not unlike how a lot of people got into this space, was really through personal experience. So I had known since I was 13 that I wanted to be a physio. I unfortunately was hit by a car when I was 13. I needed a lot of physio. And so I knew ever since then I wanted to be a physio. So of course, when I first went into physio school and graduated, I was in standard kind of regular private practice, lots of orthopedics. And I was only in practice kind of for a couple years when I started seeing how there were a lot of kind of gaps in our system. Like I often found like we were seeing clients way after the fact because they were funneling through sort of this funnel effect of our healthcare system. And now these people have a number of other issues where if they were cared for more optimally right out of the gate, like we could avoid a lot of this suffering. And it was literally I kind of almost serendipity that a few years in, and as I was kind of struggling with sort of how our healthcare system was designed, the Family Health Team Initiative launched off in Ontario. And this was meant to really sort of reframe how we deliver care. It was meant to be team-based care, and physios were supposed to be a part of these teams. And it was the idea of getting like the right care at the right time by the right person, and thinking more about health promotion rather than like a disease care system, and all of the things that to me, I thought, yes, that is exactly what we need. So I actually went and started my PhD really in this whole area of family health teams and the roles physio could play in all of that. Went on to do a postdoc all in that area. And in the midst of all of that, I got pregnant with twins. And so I kind of had my own personal journey on one side of, seeing the gaps now in our healthcare system and opening my mind up to sort of pelvic health and sort of core abdominal health. And again, gaps. So, at the time that I was starting to notice I was having some struggles, this was actually before 2012 when we had pelvic health physio was really first established in Ontario. And so, my first consultation with a pelvic physio was actually in Quebec because they've been at this much longer than we have. And as a physio, I sort of knew that's probably who I needed to see. And so it was kind of through that once our directives changed here in Ontario in 2012, and we had like an actual infrastructure to like train people to do this, I was kind of in one of the first people trained because I really felt like this is now the area of physio I kind of wanted to do. And then ever since then, all of my research, consultations with different companies, like all of the different things I do now is very much in pelvic health, perinatal care, kind of through that whole sort of lifespan, but very much through that original lens of primary care and integrated care and health promotion and health creation rather than fixing a disease. So I've carried that all the way through. And it's in ways why I would say I probably do practice clinically different than other colleagues of mine who are pelvic health physiotherapists. So yeah, that's it in a nutshell.
Yeah, I love that your work and just your mind frame around prevention and supporting people through health rather than, I think a lot of times our culture is backwards in the sense of like they wait until a diagnosis, until something happens. And so when I got into I graduated from kinesiology in 2010 and I started as a personal trainer. And when I switched jobs to another personal training studio, I had a pregnant client and I was going around to the trainers being like, who's going to take her on for me? And everyone was like, no, we don't know what to do with that. Like everybody was scared to work with pregnant women. And so that was my kind of click where I was like, okay, again, like there's a gap, so these women need support. And I didn't know that 2012 was the start because I guess like I was in and around there and I was learning about pelvic floor. I thought it was new to me. I didn't know that actually it was new to Ontario as well. I was in prenatal and postpartum care before I was a mom. And so I had the honor of getting to learn all of this stuff before having babies. So I was going around to different pelvic physios. I think I even came in to see you. I got to shadow you and I went to nutrition school. And I feel like if we can get a good understanding of where our pelvic floor is at, even before babies, then we're just in such a wonderful place for long-term health. And unfortunately, it takes a lot of women having a baby. I have incontinence or have diastasis or prolapse or anything like that, or I just have discomfort and I don't know what's going on to actually even seek care. So when would you say would be the optimal time for any woman to start seeing a pelvic floor physio? Is that something you would recommend even before having babies?
Yeah, absolutely. And what I would first say to your point is even just, and this is why it has been so helpful that more and more people are at least talking about pelvic health as sort of like a construct, because it really has been ignored for a long time. But I mean, at the end of the day, I think the more people kind of have an understanding of what is sort of optimal physiology. Like, even if I think of like the pediatric clients that I see, and oftentimes I'm mostly interfacing with their parents, but chronic constipation, bedwetting, trouble with toilet learning, some of these things, oftentimes, when people don't have an understanding of like what's basic optimal physiology and like what is sort of normal or what should I be going for? I think at any stage along the lifespan, any deviation from optimal that's sort of just persisting, then you should get some guidance, right? And anything really in the sphere of anything to do kind of with like pelvic health, anywhere along the spectrum, a pelvic health physiotherapist in most cases is going to be a very, very good sort of start. And in many cases, a start and a finish in terms of the guidance you're going to need. So as I said, guiding parents with toilet learning, with their kids and helping them navigate bedwetting and chronic constipation, where they constantly hit a ceiling when they go to their family doctor, because it's very well-meaning care providers who just don't have training in it, who will say things like, oh, your child's just going to grow out of this, or they're constipated, just keep giving them Restore-Lax, and things that are not evidence-based and frankly not true, and then set people up for problems, right? I would say in around the time of adolescence, the more we can have young girls actually understanding the difference between a vagina and a vulva and their menstrual cycle, and if they are having some discomfort through that, understanding that's just not, oh, this is, an uncomfortable experience. It's like, well, actually, our bodies physiologically are designed for this. So when the alarm system is going off through this, it usually tells us that there is an imbalance somewhere. It's an opportunity for us to get a little bit curious and address the root of that, right? So like we know, for example, even with pelvic pain, like persistent pelvic pain, which is a big issue for women, and it shows up in many different ways. It's a huge prognostic indicator if you've had sort of like persisting painful periods, that there's a higher incidence you're going to end up like this, because we just kind of like throw a birth control pill at it and suppress it and then kind of keep going. Like, so we have these funny things in the way our care systems are developed. So it's like adolescence is another great opportunity to like really understand this. And then when we move on into like perinatal, well, the data's pretty clear that it's a lot harder to kind of, even like from like an interoception or like kind of proprioception feeling perspective, to get a sense of the optimal function of a muscle when it's already injured or damaged or inflamed. And so too often we've said, okay, like you've birthed your baby, you've injured your perineum. Maybe this is an obvious time to now rehabilitate that structure. But it's like, yeah, but then if you've never kind of had a good sense of that structure when it was optimal, and now we're asking you to try to find it when it's injured, the data is pretty clear that isn't the optimal time. We want people to be aware of these structures while they're functioning optimally, like so they know. And we know that if people have good fitness capacity in their pelvic floors, meaning good flexibility, good proprioception, their sort of automated reflexes and anticipatory function of those structures are really good. The strength and endurance is there. So like fitness capacity. We see that actually leads to better outcomes for birth and postpartum, right? And I mean, then as we move on, in our wiser years as women, when our estrogen, progesterone are dropping, that does have changes to the rigidity of the bladder muscle, for example. Without estrogen and urgency, urinary urgency can go hand in hand with that. We're losing muscle mass. So pelvic floor fitness might go offline. Your vulvar tissues are kind of thinning out. They're atrophying. So sometimes we lose some of that almost integrity or structure of the urethra, and it might kind of bobble down a bit. And then stress incontinence might be more common. And so, if people understand what are their bodies doing, what's optimal, what's expected, what are the really straightforward solutions for this, so they can be what I call successful self-managers as they kind of go along, we're in good shape. So, I mean, really, I think, honestly, like full across the spectrum, because I see a lot of times too, women who I might be seeing later as they're kind of approaching perimenopause, for example, and they are having more urinary urgency because their bladders are a little bit more stiffer. But I come to learn that they have thought their whole life, you should be kind of emptying your bladder regularly, and you're going to get a bladder infection if you hold your pee. And they were training their kids to pee just in case, and all these things that are incredibly problematic. And a lot of people just don't know. And they've kind of lived their whole life with these dysfunctional behaviors without knowing, right? So I think, yes, knowledge is really critical. And honestly, the sooner, the better.
Yeah. I remember once I started getting educated in pelvic health and then going back to a regular fitness class that I would be teaching or even taking part in, and just looking at women who hadn't had children yet, and they're doing these really intense core exercises, and I'd start to see that midline kind of puffing. And I'm like, how many women have a dysfunctional pelvic floor now? And like you were saying, know your baseline, right? These muscles, we can't see them like we can see a bicep, right?
Totally.
And so just getting to understand, how do I contract these muscles? How do I relax these muscles? And then utilizing that information to strengthen your body appropriately before pregnancy and childbirth and postpartum recovery, which I hope whoever is listening to this, if you're before that point, then great. But what about those who are past that point? There's injury or there is dysfunction, and now we have to deal with that. It's not like we're too far gone at that point, correct? There's always a way to find our way.
It's never too late. And always in those cases too. And again, this is why it's helpful to have some individualized guidance on these issues once you're actually having some problems. I think following generic principles when you're literally in the phase of just promoting health is fine. But when you've kind of fallen down and now you're climbing back up a hole to try to actually create it, usually that's when even a little bit of individualized guidance is important. But you're right. Any of these kind of symptoms people might have, like heaviness, their core just doesn't activate right, they're leaking, they're having urgency, any of these things can be a combination of the status of the pelvic floor, contractile tissues, and there's multiple muscles that make up the pelvic floor. Some of it can be due with the inert tissue, the non-contractile tissue that supports everything. For some people, it's that tissue is actually more of a problem. For some people, it actually is more that muscle that lives inside the bladder. Either their brain has completely kind of trained the wrong circuitry. And now there's a lot of urgency in this wrong kind of neural circuit that we need to rewire, or it actually is an estrogen depletion issue, or it is. So yes, there can be lots of things that can happen way later, but our systems are bioplastic. So we can intervene at any time. And there's lots of different types of supports and care strategies, even beyond exercise, like compression shorts that have patented technology that will support that inert tissue. Bladder retraining strategies that are done really, really well and properly. Physios that have good sort of cognitively informed training, like that are more psychologically informed PTs are really good at these interventions. So absolutely, it's never too late to intervene, for sure.
Yeah, I like this idea of the mind-body connection. One of that really is like a core memory in my brain from when I got to shadow you was you would have someone lying down and you would touch their shoulders and their back. And I at first was like, why are we doing this? I thought this was about the pelvic floor, right? And so can you speak a little bit to that holistic, like that, the tightness in the shoulders or the jaw might be connected to that tightness in the pelvic floor, and then our own like psychological, like how our mind frame and how we view and carry ourselves in the world is also going to have an effect on our tissues as well.
Yeah, 100%. So I think this is a really important point, Steph. So, a lot of the times people will say, and I mean, I appreciate the attempt of what this is trying to do, but they might say, yeah, your pelvic floor, it's just like your bicep muscle. So, just like you need to train your biceps, you need to train your pelvic floor. And yes, there is a somatic aspect to the pelvic floor. And yes, we need to think of like rehabbing, training, developing fitness capacity in these muscles like other muscles. Yes. But also the pelvic floor is very, very unique and distinct from a lot of the other muscles in the body because these muscles are connected to our autonomic nervous system through our threat response system. So when your threat response system goes up, your heart rate might go up, right? Like you might have some of those like automated, systems that go off. And part of that automation is your pelvic floor. There have been a number of studies that have shown that when women are scared, the first muscle that automatically fires is their pelvic floor. And so we have to understand that yes, we can need to kind of look at the pelvic floor kind of from a peripheral standpoint, but we have to understand that half its functioning is connected to our central systems and our central physiology. And many of our clients who come in with their pelvic floor not working well, not connecting well with the rest of their body, actually that's the issue, is the stress response system is going off. There's fear. There's a lot of holding of these muscles. And you can pick that up, that kind of central phenomenon, through different questionnaires. One that I run on all of my clients is called the Central Sensitization Inventory. And also, as you said, by just, before you kind of zone into that area, just getting sort of an appreciation for what is their whole body kind of holding, right? So absolutely, like we have to understand that like when we're doing anything to do with pelvic health, we have to not be tempted to, like, I always use the plant analogy, where is sometimes, especially as physios, we can be guilty of this. You walk in, you see a plant, maybe one of the leaves is kind of like dropping over. And like oftentimes the physio approach is very like mechanical and peripheral and like, oh, let's see what we can do at the level of the leaf and maybe like prop it up. And whereas taking a step back and understanding, yeah, but most of the leaf is actually getting its stuff from the soil. So let's actually just get the soil good and then the leaf will get good. So that very much is how I practice. Like I don't do much honestly anymore at the level of the periphery at all. It's not to say that that's not sometimes helpful. It's just to say I think the value of it is very, very low compared to really getting to the more central factors.
Yeah, I love the connection between fear. I think that there's, it's our root, right? And I think trauma, especially, there is probably the likelihood of having tightness or dysfunction in the pelvic floor is probably heightened. And it makes me think about, women who are in labor and they're laboring at home and then they're transferred to the hospital. And then there's a disconnect between like the hospital and perhaps the midwife who's like, well, she was this much dilated. And now the doctor's like, no, she's not. She's only 3 centimeters. And I think that's, would you say that that's because there's fear in that transfer to the hospital, and things being up in the air. So we kind of tense up and close up a little bit.
100%. I would say there's really good data to support that. Yes, when our threat response system goes off, that does a whole cascade of things in our physiology. So even that means when you're in the middle of labor, one of the worst things you can have is all this like sort of adrenaline and cortisol. That's going to like stomp out everything else that you need, right? Because you're really designed to actually birth and surrender when you feel safe, right? And so the physiology will shift. But also, yes, we know that we have this, direct relationship between threat response center on, pelvic floor contracted, right? So absolutely happening kind of both on a mechanistic perspective, but also a hormone physiology perspective for sure.
Yeah. And so when I was doing my kind of field work, going to different physios to understand the practice, really, it was very interesting to experience different types of physios and to speak to what you're saying. A lot of physios are approaching it, the leaf approach, right? Let's prop the leaf up. I had one physio who essentially was doing like tissue manipulation the entire time. It was like massaging out the tissues. And then when I would come to see someone like yourself and just this more holistic perspective, the intake that you would do, the questions that you would ask, it's so much bigger than that. So I think with any modality or professional that you're going to see, it's very important to find someone who is going to look at the big picture and not just like, hey, your pelvic floor muscles are tight, let's loosen them up, right?
100%.
And so in your practice, what would you say are some of the best tools that we have access to in order to help when there is pelvic floor dysfunction, whether that's diastasis or, I'm sure it changes based on what the diagnosis is, but what are some things that we can do other than that internal manipulation of the pelvic floor?
Yeah, absolutely. And there's lots, because at this point in time, Steph, I don't even know if you know this, 100% of the care I deliver now is virtual. So I don't even touch my clients at all. And and how that kind of started was first through COVID, like all of us had to, for a short amount of time, revert to that. And it was able to show me how powerful, really, really excellent kind of cognitively informed care for someone who has a ton of experience in this area. I can sort of recognize patterns and things like that. So when I went back to clinic, when things opened, I only ever opened back up like half and half. I still kept half my care as virtual. And then as I was sort of dwindling down how much clinical care I was doing, because I'm doing so many other things, I was sought out so often by people all around the world who have like seen 5 pelvic physios already and getting like the peripheral care that's so low value and doing very minimal, quite frankly. And it kind of showed me that like with my skill set, how I have it now, I can actually do so much without even like touching people. And my schedule just got so full, even with all of this, that I just kind of shut down my in-person practice. So I'll certainly, like, people who haven't been to in-person physio before, if as we talk to them, I think it would be useful. I'll suggest that. But yeah, so to that point, there is a lot. I think actually the higher value things are sort of outside of, kind of releasing the pelvic floor and this type of thing. So what I would say first that I think is actually the highest value is for you yourself as someone who has had sort of symptoms or difficulties. And a lot of the times these symptoms and difficulties do make people scared. So it kind of comes back to that fear you were talking about, like, oh my goodness, I'm having this symptom, or I see this like bulge coming out of my vagina, or it's frightening, like it's terrifying. So it's kind of like that fear ends up being a big part of this often, not always, but often, like fear, shame. There's a whole bunch of things that go on. So what I think is most important is actually that people are able to engage with someone and leave that encounter understanding much better what's happening in their body, and therefore then not being afraid of it. Understanding, okay, this is likely what's happening with this structure. This is likely what's happening with this structure. I've now come to understand that these issues are quite common given the type of birth I had, or given that I've had chronic constipation for 10 years. Like, it's not sort of a surprise and like a weird thing. It's like, yes, it makes sense that this is the way your system's going to adapt given these experiences. And then these are the expected symptoms one might have with this. But the good news is then we can do lots of things with it. So sure, there's the manual therapy. There is different exercises, right? Exercises, not just for the pelvic floor, but helping people to understand how we want the pelvic floor to coordinate well with other muscles of kind of the trunk and legs, for example. So we're like managing our sort of manometric pressure system better, right? We can talk to people about sort of just everyday habits that they have that they just might not notice, that they're in such a habit of holding their breath every time they're doing tasks that really you shouldn't need to hold your breath to generate that much power to do these rudimentary tasks all day. Like, can we adjust people's everyday behaviors? A lot of the times people have adapted to really unhelpful bladder habits because maybe they have hit a juncture where they haven't trusted their, pelvic floor or their sort of bladder control as well. A lot of the time when you have a baby, this is one of those times, like you kind of feel like things just don't feel as secure around there. So you know what? I'm just going to go pee a little bit more often. Always just keep my bladder empty just to kind of make sure. And people don't recognize that that is very, very problematic. They'll set up an overactive bladder, right? And so I think for people just to understand for them what's going on, and then, we have behavioral strategies, we have exercises, we have our different lifestyle interventions that are huge. An inflamed physiological profile in someone who's not moving a lot through the day, that can spin off to a whole bunch of not so happy leaves. If we come back to our plant analogy, one of them being the pelvic floor, right? So even helping people to kind of understand the importance of good physiology, not just for their pelvic floor. And so this is where like a lot of sleep stuff comes in. This is where we come back to the stress response system and help people to understand that if you're living your days in sympathetic drive, it isn't going to be constructive for many things, including your pelvic floor. There's a number of other supports like the external compression garments that I talked about, internal sort of pessaries that can support. There's different electrotherapy devices that are on the market now, some of which are really, really good. So there's a myriad of like a whole menu of options, many of which, even if you guide someone how to use those virtually, they can kind of go off and buy them and kind of start again being a successful self-manager, right? So there's a whole menu of options of things that have a really good evidence profile, I must say, that people can use.
Yeah. A lot of my clients, women that I work with, a really prominent theme that I'm seeing is this kind of type A personality, perfectionist, sense of urgency, high strung, high stress, gotta go to work, gotta drop off the kids, don't have enough time to do all the things in my day. And they're just kind of like spinning their wheels. And it's interesting from a weight loss perspective. I'm helping people with fitness, nutrition, mindset, and sleep. Those are kind of the pillars that I work with. And the mindset and sleep are really, I would argue, where the real work is, because it's easy enough 100%. To say, okay, we need to work out 3 days a week for 30 minutes, like, challenging all of the muscle groups and eat this and not that. Like that's the easy stuff. It's how are you approaching everything mentally, right? Can we choose peace? Can we choose ease? Can we find a way to rewire the brain so we're not in this constant state of revving? And I can only imagine the effect that kind of archetype has on the entire body, including the pelvic floor.
100%. It's exactly what you said. I mean, one of the things, and again, I would say this is actually probably why I have found that, and why I probably found through COVID when I was forced to do my initial consultation virtually, right? Like I was forced to, because we were all doing everything that way. And then thereafter, the only way someone could see me was to first do virtual as a consultation, because I actually found it allowed me to get way further because it gave me the full hour to talk to them. There was no sort of expectation on either side that we now have to get on and start physically assessing things. Like it was understood that this is how we're spending our time. But you are quite right that oftentimes by the end of an initial consultation, if that is an issue for someone, and it is for probably 80% of the people I see, that they are kind of in this operating rhythm of putting themselves last, everyone else first, and they are finally kind of coming to a visit. So in ways you could say, okay, well, they're putting themselves first now, but it is literally because they are drowning. And like, if they don't, like, it is going to be a big problem, right? Like it's been left kind of so long. So I help them to see that. I help them to see, like, look, our systems are always giving us sort of communication, and pains of communication, heaviness, incontinence, waking up 10 times through the night. Like these are all forms of communication. And we've been so trained to like misunderstand what our body's actually really trying to tell us. And it's like your body is trying to tell you that how you have been going about things is no longer sustainable, right? And so we need to actually just start listening, because it's dialing it up louder and louder and louder with other symptoms. So we just have to recognize, yes, like we are done with being at the bottom of the barrel, right? We have to start. And so that has to be kind of part of what we come to. And I can say, like, look, there are some low hanging fruit, sort of easy wins we can kind of do to get you going and feeling a lot better quicker. But I mean, eventually we have to start targeting this exact way you said, the way you kind of show up every day and your way of being, because it is no longer sustainable. And your body is making that very, very clear. Right. So
Right.
it's kind of coming to like that side of things. Mm-hmm.
Yeah, I love that. And I love that, there's so many blessings from COVID times that, we learned how to slow down a little bit. Everyone was home, working from home. We learned how to do things differently. And I think that, as you're saying, it's even benefited your practice, which is kind of
100%.
mind blowing, because you think that was one of the first things I thought of, like, how are people going to do pelvic floor physio? Because it's very hands-on as far as I'm concerned. But, now that we're talking about it, it makes so much sense that it's just so much bigger than that.
100%.
And so with pelvic floor physio, there are kind of like the umbrella of issues that people will generally come to you for.
Yep.
I want to talk a little bit about diastasis, because I think it is such a misunderstood diagnosis, right? Yeah. When you think of like abdominal separation, people thinking their abs are literally like just flopping out apart from each other with nothing connected. So can we talk about what is diastasis and what do we need to understand about that? Because I know that it's not just about the, how far apart, how many finger widths apart that diastasis is. It's also about function. Yeah.
100%. And you're so right. This is not only confusing for what I would call like health consumers, like people that kind of are looking like for help, but it's also really confusing for healthcare providers, fitness providers, and the like, right? And it has been for a long time. This was actually an issue that I was having after I had my twins. My abdominal wall was, not working particularly well. And it was interesting. Like I really struggled to get good guidance, even from pelvic physios at the time. So I ended up getting into a lot of research on this myself, right? And almost becoming like an expert on it myself, and then being able to first help myself and then help all my clients. But really what people need to understand is that the label of this thing in and of itself, I think, is like a good bit of the confusion. So it's called diastasis, right? which in Latin means separation. But actually with the diastasis, nothing is separated. Separated tissue is a hernia, right? So what happens is as our bodies are so amazing. I mean, they adapt to be able to grow an entire human being, right? And a new organ, the placenta that supports this human being, like it's incredible. So with that really amazing, intelligent design, the tissue, the connective tissue that is between our two six-pack muscles, right? We refer to it as the linea alba, but it's kind of 3 layers of tissue. And it is designed with this adaptive capacity. It is designed that it is meant to thin and widen to accommodate the uterus growing, right? So it's supposed to do that. And then not unlike the cervix, after you have your baby, I mean, your cervix is going to efface, dilate to 10 centimeters, and then go back to normal again, right? It's adaptive tissue, right? This is adaptive tissue. So, if all is going well, you birth your baby, you recover through the 4th trimester, the first 12 weeks postpartum, and that tissue reorganizes itself and readapts, and we're good to go. And that is the case for 50% of women. But we have another 50% that somewhere along the line between this adaptation process and the postpartum, something's happened that this tissue didn't reorganize itself well again, right? And so, in situations where there actually did get a separation, there was actually too much strain to, sure, this is a hernia. And hernias do go hand in hand with kind of these thinned out abdominal walls in a certain proportion of cases. That was actually something that I had trouble with. I had 2 massive babies in a pretty small frame. Not only did I sort of stretch that tissue adaptively, it overdid it in my case, and I had 2 massive hernias. So until I kind of had those repaired, that's why my abdominal wall wasn't really reorganizing well, right? But there could be other reasons potentially, and this is where we really don't know for sure on this topic. The research is still pretty muddy. But there are some thoughts that, well, is it possible that while that tissue was sort of thinner and wider and arguably a little bit more vulnerable, that said individual was in a situation where they kind of had to put forces that were too strong for that structure during that time, and it actually did get injured, right? It actually did deform in an architectural way that then it didn't reorganize well. Like, did the person kind of get sick with bronchitis while they were pregnant? It was tons of coughing on this structure, really, really bad constipation that can happen. Or, like, were they in a scenario where they really had to suddenly like lift something, or they sort of fell, or there's a whole myriad of reasons. There's also some data linking when your physiology, your blood sugar regulation isn't good, right? So gestational diabetes, for example, we know that that's actually a state that kind of goes hand in hand with your type 1 and type 3 collagen not being very good. So there's some thoughts that, if we have some dysregulated physiology that way, is that a bit of a problem? And then we also see that a cesarean birth is an independent risk factor. And we suspect that that's kind of more about like the manual maneuvering that's done to get baby out. Does that perhaps injure some of that thinned out tissue? The fact that, in around the scar is so rigid after, that people who don't really know that they need to get that moving nicely again. So they have this rigid band for a long amount of time. It doesn't really allow very good load transfer. So it's possibly overloading pressure wise, like above that area. So we have some thoughts. We're not sure. But really what we should understand is, look, when this tissue is kind of thinned out, probably it is a little bit more, it is a little bit less robust than it was before. And we just have to be intentional about that. So just understand that through pregnancy as you're moving, and understand that in the postpartum as you're recovering, but really, if we can kind of understand it for what it is, I mean, it should never be pathologized. We don't have a label for the state of when your cervix is effaced and dilated, right? It's just so weird that we've kind of come up with this thing. But I think to acknowledge, look, if you're one of the 50% of people that your abdominal wall didn't reorganize well after, like you're beyond 12 weeks in the postpartum period and just still not connecting well, then connect up with someone who knows about this and get some guidance, because there's just tons we can do just to get the system back on again.
Yeah, so it really depends if you've had a C-section. If not, how was your diet? How was your hydration? How was I would say, even the connection to your pelvic floor beforehand, right? Like
100%.
I was sitting there doing deep core breaths through my whole pregnancy because I wanted to keep that connection to my core. And then
Totally.
also talk about the the deep core muscles, right? The transverse abdominis. And if is that what you would refer to as like a functional diastasis? So even if the integrity isn't there 100% in the linea alba, if you can get your deep core muscles activating properly, then you're in a better position, or at least on your way.
100%. I mean, certainly that's where we're going to start, because we know that like really getting like the inert tissue, like some of those other fascial layers, that's always going to take a lot longer and a lot more consistency, right? It's like a ligament injury is like 12 weeks, whereas like a muscle injury is 4 weeks, right? So absolutely, we get the muscular system fired up. We get the neural patterns more optimized. We kind of drop sort of habitual habits that probably aren't helpful. Like we do all those things first, but we understand that in order for it to carry over and have a carryover effect to that inert tissue, which eventually we do want, right? We have to have a degree of like consistency and progressive overload through the abdominal wall. So there's some of these principles that sometimes get lost. I mean, I've seen people who have come see me and they've seen however many practitioners first, and it's been like 15 months since they birthed their baby. And they've said to me, don't worry, I'm not doing any sit-ups. I know not to do that. You know, I know all that. I'm just going to be doing this. And I'm thinking, oh my goodness. But at this point, we actually need you doing a ton of concentric activity to pull the tissues in. So like you need progressive overload. It's a matter of like, there's a certain time and place for certain things, which is why, you know, I think people just need a little bit of guidance through this. But absolutely, people shouldn't be afraid of the ability of their abdominal wall to adapt. I think it's just really been misunderstood. So yeah, certainly lots I think we can do proactively to kind of make it more likely the structures will reorganize themselves well again, like prevent any obvious injuries, which I include immune system sort of status in this, because there's a lot of people who are very, very sick all throughout their pregnancies. And that's a hit for the pelvic floor as well, right? That's an independent risk factor for prolapse, is persistent coughing. And so it does become my business to say, well, let's look at like, why is your immune system so compromised? You know, like what is going on with that? Because, you know, it's going to be very difficult for us to really kind of come through with the pelvic health status that you're interested in if there's these ongoing micro assaults because your immune system's not good, right? So this is again where we have to think of like the whole system. Chronic constipation is the same thing. We have to think about the gut and the microbiome and all the things, because it's an independent risk factor for these pelvic health issues, right?
Yeah, I mean, that makes a lot of sense, that
Yeah.
we need to look into why are we coughing all the time? What's going on? How does the body, it always comes back to like the body is communicating with us. It's trying
100%.
to tell us something. What is it trying
Totally.
to tell us? Like
Exactly.
the cough. And if we're approaching it from a medical viewpoint of like suppress the cough so that you're not coughing anymore, well, you're not fixing the root of the issue, which is like, what is your body actually trying to excrete?
Yes, totally.
What
Or trying to
cleanup
express to you. Yeah. 100%. 100%.
Yeah, so that's huge. And then can we talk a little bit about incontinence? This is something that a lot of women face, and I think it almost carries through. Like, you know, people laugh about it all the time, like, oh, after you have kids, you'll never be able to sneeze without peeing again, right? Like, that surely doesn't have to be the case. So what's happening there?
Yeah, 100%. And I mean, this is a big sort of soapbox thing for me because, you know, as I said, my roots kind of started in primary care. Well, I teach at McMaster University. I teach in the physio school, but also the School of Medicine. So I teach the family medicine residents their sort of pelvic health module and rotation. And really, I'm trying to make sure that they in their practices are understanding that help seeking for these issues is low. And a lot of the reasons why people, I think, deal with these issues is they don't have a good understanding that when conservative care is executed well, it is extremely effective, right? So we know that, you know, giving someone a handout that says Kegels, that doesn't work. But doing more of an individualized pelvic floor muscle training approach works really well, for example, right? So yes, people I think aren't coming forward for help. This has kind of been normalized, or people have heard of friends of theirs who have kind of tried some of these like conservative care approaches and they haven't worked for them. So then they figure like those aren't really valuable and they're maybe not a good use of time. But I can tell you, when things are executed properly, there's no other area of physio, I would say, that the care strategies are more effective, honestly, than some of the ones that are developed for incontinence, right? Like they're really, really effective. So yeah, as I said, you can have leaking from the pelvic floor, not having any aspect of its fitness capacity. So it's not just like it's weak. It could be that it is not flexible enough and it's holding too much tension. There's not enough blood flow and it can't respond on time. It could be that it's weak. It could be that the tissues that kind of support the urethra and kind of support everything have sort of taken a hit over time and they're not functioning well. So that could be the problem. It could be that just kind of slowly, sneakily over time, you haven't had incontinence, but you haven't trusted your bladder sort of control as well. So you've slightly adapted into these more defensive voiding techniques. And now you've wound yourself up with a really overprotective bladder muscle that now is no longer trained to store urine. It's only trained to empty urine, and now it's going to empty urine on you. So it can be a variety of these things that can happen over time. Certainly the pelvic tissues take a hit with birth, and certainly in perimenopause and menopause, the reduced estrogen, we lose some of that tissue, like I said at the beginning, the plumpness of that tissue, and we get more rigidity in the bladder muscle. So, I mean, these are all things that can happen through the lifespan, and it can be any of those kind of tissues getting in the way, in addition to anything that drives the function of the pelvic floor in the first place, which of course is all those central things, right?
Yeah. Yeah. So the moral of the story is seek help so that you can get the
100%.
personalized care that you need, because this is it can be coming from so many different
and
aspects.
very common, but you're right. A deviation from optimal, right? Common, but represents a deviation. It's a communication. Your body's trying to tell you like something's not right here. And so let's get curious. Let's listen to it. Let's, get to the root of it. And very basic strategies are very effective, right? So absolutely, this needs to be done better in primary care. I don't know of any other university in their med school, honestly, that even does the curriculum that I teach the docs there. So even that's a problem, right? Like we need this better at all levels of the healthcare system, but at the very least, you can rest assured if you're working with a physio who really practices, from kind of like this integrated perspective, you actually need very little guidance. Like I usually only see my clients a couple of times, and then they are well on their way to successfully self-manage.
Yeah. Yeah, there's a disconnect between the medical world and all of the other care modalities that we have. Like I would love to see doctors writing prescriptions to pelvic floor physio. Like, there is care for this. And then if nothing else, like you have to be your own healthcare advocate. You have to know that there's a difference between what's common and what's normal, right? Of course, it's super common for us to be leaking urine after having babies or when you're going through menopause, but it doesn't mean that has to be the reality, right? So just realizing that, like, okay, I actually have the power to change this, and all I have to do is reach for the help that I need to get the right tools in place for me to overcome this.
100%. Yeah. Yeah. I think you said that perfectly there, Steph. I agree 100%.
And then what about prolapse? Can we talk a little bit about prolapse? There's 4 prolapse, right?
Yeah.
So for some people, it might be, very minimal, and others might be literally tissue coming out of the vagina. So how do we approach that?
Absolutely. And so it's interesting when we look at the stats for urinary incontinence in women across the lifespan, the stats tell us it's 1 in 3. I suspect that's sort of an underestimate because we know that there is underreporting on these things. But for prolapse, it's actually established as 1 in 2. And I'll be honest that when I first learned this, when I was getting trained in pelvic health, I actually didn't believe it at first because I hadn't really heard of prolapse before, whereas I had heard of incontinence. But I can tell you in my, 20 plus years as a clinician, It is. It's very, very common. Now, it also is something that tends to be a lot scarier for women, right? Just kind of the thought of like their organs coming down. And a lot of the times people have kind of gone to Google before they've maybe had a chance to talk to me or someone else. They're really like freaked out, and I have to kind of almost
Mm-hmm.
talk them off a ledge and say like, no, it's okay. This is just what's happening. And this is how we're going to solve this problem, right?
Mm-hmm.
But you are quite right. We have a scenario, and usually prolapse is something that occurs sort of slowly over time. So oftentimes it can start out with, and I mean, what I'm going to be saying to you, these are established independent risk factors for prolapse, right? So vaginal births with the use of forceps, or third or fourth degree sort of perineum tear in the birth. So you can imagine, a birthing process that was a little bit more arduous, right? You can appreciate that that is likely going to have a particular impact, not only on the pelvic floor structures, but some of the other sort of tissue in that area. And we do see that then over time in these individuals, that kind of whole support system from the bottom, particularly if these people didn't rehabilitate themselves right away, because often they're not guided to do so, right? Over time, we're going to get some of the suspending fascia from the top is going to start splintering because you just don't have the support from the bottom. So oftentimes this is something that does occur over time. But yes, it does kind of drop down in stages. So we have at stage 1, which is a stage that a lot of people actually can't even really feel. Some people can, they can say like, it just feels like lower or heavier towards the end of the day. So that would really require a healthcare practitioner to kind of go in and check and say, yeah, is this sitting down lower than it sort of should be? A grade 2 is when the tissue comes right to the vaginal opening. So this is when the person with the symptoms could actually look down and say, oh man, I can actually see something coming really close to the opening or right at the opening. That's grade 2. And then grades 3 and 4, when like the tissue is protruding out of the opening. And when we're talking about grade 1 or 2, the clinical practice guidelines are conservative care, right? So even the urogynecologist that's here in town with me in Oakville, Ontario, her name's Dr. Carolyn Best. Her and I collaborate quite a bit. I worked out of her office at one point. She doesn't even want family docs to refer someone unless it's a grade 3 or 4, right? Because if she ends up seeing someone and it's a lower grade, she just sends them back to physio, right? So the point is, this doesn't need to be a scary, scary thing. Even if it's to the point you're kind of seeing something, this is well within the realm of many of our established care strategies, not unlike the ones I already talked about: pelvic floor muscle training, use of a pessary, really getting your kind of intra-abdominal pressure managed well, using kind of supportive compression, like any of these things, right? And then for grades 3 and 4, that still doesn't mean surgery. We have pelvic health physios now who are really good at fitting pessaries. It's sort of more of an advanced practice area for some pelvic PTs, and that can be a really great option for people. So yes, prolapse is common, but it doesn't need to be scary. There's lots we can do, but it's also why I would say an ounce of prevention is worth a pound of cure. Like, this is why we want people understanding what their pelvic floor should be doing before they even get pregnant. And then keeping those systems good and understanding about pressure management and having good bowels and all of those things. And hopefully then having a birth that doesn't have any of those interventions that we know are problematic for the pelvic floor, and so on and so on, right? So yes, prolapse is also a very common thing, but does not need to be scary. There's lots we can do about it.
Yeah, and comes back to what you were saying earlier about like the fear and the shame, and I think
100%.
it can hold us back from getting the care that we need, because that paired with putting ourselves last and being that like martyr archetype, it's a recipe for disaster. So if you take one thing from this talk, it's put yourself first, take care of yourself, and then you can
100%.
show up better for everyone else that you need to show up for.
100%. And the other big thing there too, which is obviously, near and dear to both of our hearts, is the exercise and movement side of it. So one of the first things people stop doing when they have prolapse symptoms is moving and exercise, because it's something that oftentimes without the right supports, it feels more symptomatic when you're moving and exercising. And I mean, we cannot have that. We need women feeling safe and comfortable in their bodies so they can move their bodies. It is critical, right? And so absolutely, that is another reason why we need people to understand movement is actually your friend. Sometimes the symptoms you're feeling can be more related to kind of the sensitization of your tissue and the fear, and doesn't actually necessarily align with anatomically what's happening. Like, so we also have to make sure people understand that, but we need to get people with the supports that they continue to move and be healthy and fit. It is critical. So yeah, so that's another piece of it too.
Yeah. And I think that comes down to like the pressure's on and for the fitness professionals to get educated around all of these things and know how to support a woman who is
100%.
Pregnancy, postpartum, all of these things. You know, there's so many like, you know, mommy boot camps where they're doing like jump squats and burpees. It's not necessarily the appropriate exercise for them to be doing at that phase.
100%. And I would say on the flip side, and for some it might be. For
Yeah.
some, if they have the systems capacity that they can manage that and they want to do that, and that's what makes them feel good, then I would say, okay, great. But we at least have to make sure people understand, okay, like if you're leaking during that task, your body's mechanically failing. So you want to make sure you're listening to that and modifying accordingly. Like, so it's still like what might be good for one mama might be quite different from another, because we all come in with different sort of capacities in our systems.
Yeah.
But people at least need to know how to interpret certain symptoms instead of interpreting things with an unnecessary amount of fear or an unhelpful amount of just ignorance and just pad up and play on, and then they end up with a prolapse, right? Like we have to kind of get people understanding, like, this is what optimal function looks like. When you deviate from it, there's lots of things we can do to support it. So, you know, just engage with someone and we're good. But yeah, we want fitness providers to not be afraid of women who have these symptoms, to not be afraid of, because chances are they're already scared to move and they're looking to you for a sense of sort of security and confidence. It's like, so when in doubt, sort of start small, start with basics, understand that definitely like walking is not going to damage anyone. And walking is actually a proven intervention for incontinence, right? So like when in doubt, there are always basic things you can really, really reassure your client. Okay, for now, we're going to make sure we're hitting our 150 minutes walking a week, and we're going to do some of these specialized things. And I'm going to reach out to some people to kind of just make sure I have some really good guidance, and I'm going to come back and kind of, we can tailor it a little bit more. But yes, fitness providers, do not be afraid of these clients. They need to exercise. They need to move. They need to feed off your confidence.
Yes.
Yeah.
Well, I really appreciate everything that you've shared today, Dr. Sinead, and I could just keep asking you questions for the rest of the day. But if people want to learn more about you or even potentially work with you, how can they find you?
Yeah, probably the best place to find me is either through Instagram, like through my Instagram handle, which is dr.sinead, or LinkedIn, which is just Sinead Dufour. Or if you want to learn more about me and find my email address, you can go onto my McMaster Experts page. So you literally just Google in Sinead Dufour McMaster Experts, and my page comes up with all my publications, and my email address is there. Those are probably the best ways.
Amazing. Well, thank you again for joining me today. And yeah, take care.
Okay. Thanks, Steph.
Bye-bye.
Bye.